Okay, well, we have time for a few questions, and I'm taking the liberties of asking the first one while you get yourselves organized. So, this was a great panel, and thank you all so much. So, given that no amount of research will satisfy everyone, and the perfect is the enemy of the good, that we work in a market-based system that's not too integrated, that there are intangibles such as the invisible architecture that somehow need to be captured, but there's no real measurement for that, and that translational science may offer some solutions to us as we look at the nurse credentialing research agenda. What I want to ask you each is, if you could give us just one piece of your best advice to move this agenda forward, what would it be? And I know Sue Hassmiller wants to go first. Oh yeah, she has to turn that on. You just have to turn the little.
Here we go. Is it on? Okay. So don't let perfect be the enemy of the good. We all want to make a difference. That's why we're here. That's why we're here in this room. That's why we're on Earth, right? And if I have learned anything by living at Robert Wood Johnson Foundation, which prides itself on being a social change agent, an organization that makes things happen, implements policies, gets people moving in the right direction health-wise, is that there is a balance. We have a big research shop and we have a big communication shop. And we have finite resources. And the key for us, and perhaps the key for all of us in this room, is to think about those resources in the big picture of trying to make change. How much should we devote to research? And we must, right? And then how much should we devote to communications and messaging and advocacy? And we do both, and all of that at the foundation. And I was thinking about, so when do you make the switch? When do you say it's enough with research? Well, I think the first one is when the research questions have been answered. That's the easiest one, right? And the second one is to, and you have to get out of yourself and out of your work and notice that as hard as you're working, nothing is changing. The policies are not changing, right? So you've answered the questions, the policies are not changing. And the third one is when you have determined and you know that it really doesn't have to do with research anymore. It has to do with politics. And those are the three things, and you might think of more, those are the three things that I can think of as to when you change your resources and change your mindset. Take what you have and begin to look at the communication, the messaging, and advocacy to make that difference.
So while my heart tells me to have the research appeal to the individual clinician, my brain and my MBA tell me you have to appeal to the marketplace. Biggest bang for our buck is to convince the employer, therefore the payer, therefore the government, that credentialing equals quality and efficiency and helps us get to the triple aim. I think, I always say marketplace rules. So, always think about the employer, the big employers. And we think over time across the country, there's just going to be a handful of big employers. Mm-hmm. And so if the employers across the country are convinced that credentialing is going to benefit them, it'll just, take place. So I would say, put employers or the marketplace at the top of your list to appeal to.
Ken or Sheila?
A shorter way of saying what was just said is follow the money.
It's great. Oh, thank you, Sheila.
And I would say, think about the tipping point, or think about credentialing doesn't require 100% of persons in the unit or 100% of all those employed. What is required is enough, and I'm not sure what that enough is, but enough of the nurses and the other persons in the team credentialed that in fact there's regression towards the mean of practice, that is the mean of credentialed practice. And ultimately that you will also get regression towards the mean of getting the rest of the folks credentialed.
Thank you. The committee, Jack?
Okay, so let's follow the money. The last item, or the bottom of the framework, had business case. And we know from the literature on business case, Sheila Leatherman's article on health affairs, work I published on nursing, is that at least under traditional payment mechanisms, there are a lot of quality improvement activities that are socially desirable. They meet the overall cost-benefit, cost-effectiveness standard, but they don't save money for the organizations that have to implement them. So, Kathleen, Ken, I would ask you, where do you think the sense of current leadership is on whether the credentialed personnel pay for themselves, and how important is it to have a research agenda that is focused on assessing whether they pay for themselves, in which case we don't have to increase payment, or whether we should be paying more for the quality that credentialed staff bring?
So I think the cost, although as far as my role in my organization, I always talk about the investment into implementing credentialing, that it's a sunk cost. Just a sunk cost, right? It's like starting up a business. So, so that's where I would categorize. You know, healthcare organizations implement a lot of stuff and waste a lot of money. The more innovative you are, the more money you're going to spend, right? Eventually, you may hit it. But I would just categorize it as sunk costs, and I think it's a matter of what the leadership is in the organization, in terms of their vision. You know, things aren't black and white. You can't wait for 100% proof on stuff. You know, there's no such thing as perfection. You have to go along and course correct, you know, as time moves on. But, you know, with the assumptions that we make around credentialing, we think that in terms of whether it's the new financing models or the traditional financing models, and we have this picture of, you know, the leadership like trying to cross a chasm, right? So we have the traditional model. We're still being paid the old way, but we have to turn this big ship around to get to the new way because you can't start too late. There are just some things that we need to do. And we think that, you know, credentialing and investing in the workforce is a big strategic initiative that we think will help us reach the triple aim eventually.
How you look at that depends on your financial model and what type of payment system you're under, because you will pursue things very differently if you're in a global payment scheme as opposed to fee-for-service. And you know, as long as we have our anachronistic fee-for-service model that dominates the market, then a lot of these things won't make fiscal sense. You know, I have had this conversation with the last 2 or 3 CEOs of a very large HMO in this country, who says it costs them just as much to have a nurse practitioner as it does a primary care physician. And so there's no real business case for using credentialed nurses because it costs them just the same. If you, under a global payment scheme, whatever that means, then you can start shifting things around as long as you can deal with your direct costs in a sense. You know, just to take the case of a pharmaceutical product that came out not long ago, well, quite a while ago now, for schizophrenia, which markedly reduced inpatient days for schizophrenics, but drove the pharmaceutical budget up through the roof. But the net was a substantial savings because there were so many fewer days in the hospital. The problem with that, though, is that so much of your hospital costs are fixed costs, so that unless you can deal with the ones that aren't fixed, then you may or may not end up saving money. So it really comes down to what the financial model is that you're implementing this in, whether it makes a business case or not. And you'll have different results depending on which model you're using. But hopefully, you know, fee-for-service is dead. It doesn't yet know that, and it's kind of on terminal life support. But there will come a time before long when global payment of various forms is the norm. And a lot of these things will then make a lot more fiscal sense than they do today.
Thank you for the committee, the planning committee, sponsors. Any other questions? We'll open it up. Oh, thank you. If you could just tell us who you are, that'd be great.
Hi, Allie Neal, Heuristic Solutions. Sheila, I had a question for you. Did I hear you say that if the employer, if the ER record captured the credential status on the signature, that you'd be able to link the procedure with the outcome with the credential status in a large data set?
Yes.
So is that the logical?
It's only in those electronic health records that have the architecture and
right.
actually have gone through it's a fairly rigorous process of figuring out scope of practice and then making sure that, and then the credentialing, because we heard that the issues of what is the credential or multiple credentials that a person has, and then if you're going to attach that to their signature, I don't at this point in time in my head have a way that you could parse out the difference between multiple credentials. For example, APN plus oncology. So is it the oncology education or the APN education that made a difference in those outcomes? All you'll know is the person was credentialed and they were advanced practice or they were a registered nurse.
So, but does that, I mean, it seems like the elusive question that I've heard thematically today is just linking those pieces together in some data model somewhere, which is really understanding that the outcome as it relates to the procedure, as it relates to the attributes of the professional who's delivering that particular procedure.
So if you went back to the APN that also has oncology certification, if in fact what the problem or the assessment that she's documenting against the interventions that she did in the outcomes, if they were strictly oncology, then you could, in terms of doing a query of the data set, be able to say, oh, the X percent of nurses caring and doing this, doing these assessments, do these interventions, and these are the outcomes, and X percent of them are credentialed with either a specialty credential or advanced practice and a specialty credential.
Thank you.
Any other questions? Yeah, thank you.
Hi, I'm Pat Patrician from University of Alabama at Birmingham. And I have a question for both Kathleen and Sheila. And Sheila, you mentioned that 10 years ago, the practitioners might have gone to school and they haven't heard a thing about EBP, evidence-based practice, and so they haven't learned about translational science. I would also say that 5 years ago, people haven't heard of QSIN or quality and safety or any of that that might help us move quality forward, maybe even, dare I say, faster than certification might. How do you, especially Kathleen, how do you translate QSIN into the practice setting for your staff so that they understand quality and safety? And also, Sheila, how do you make that happen with practitioners who might have been out of school for a while? Thanks.
So we have, coming out of our corporate university, one of the areas that we have our head of quality and their faculty put together curricula for that. And it's not just QS, it's not just for nursing, but in fact, it's for the whole clinical team. That's how we, create our curriculum over there. So that's one thing. The other thing in terms of is, giving the staff the improvement sciences skills, be it microsystems, Lean, Six Sigma, again, so that they can identify issues differently and have half a chance of putting in new processes that don't, go back to the old processes. So we have multiple ways of doing that. Also our residents, 120 residency programs. They all come through and have quality programs. With our children's hospital, our pediatric fellows for 5 years straight had to come through our white belt class, each and every one of them, so they could bring that skill set back to the hospitals.
In terms of CUSIN and the care coordination and transition management, for every dimension, we had the authors of the chapters in the core curriculum develop KSAs, knowledge, skills, and attitudes from the literature. And in the case, if there was a case where there wasn't something specific to an activity that was part of a dimension, then they, as experts, developed a set of KSAs for that. And as a result, the CUSIN Institute has endorsed the Care Coordination and Transition Management Core Curriculum. In actual education, part of what we do is we have it integrated at the graduate level in specific courses. And the courses I teach at the DNP and the master's level have the CUSIN competencies in the quality course. I have it in the DNP course because they really do need to become comfortable and proficient with the use of the KSAs. At the undergraduate level, it is integrated across the entire curriculum at Loyola.
So I would just ask that you join me in thanking this implementation panel very much, rounding out our day. And thanks so much. I'm going to turn it back over to Bobby Berkowitz.